Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
Tonight, we're going to be delving into the world of brain and to some extent spinal cord tumors. These are not super common cancers. They're not like breast cancer or lung cancer or colon cancer, which you hear about on a daily basis. But they're very important cancers, both because they can threaten people's lives and because oftentimes they cause a great deal of disability. Tonight, we are joined by Dr. Sylvia Kurz, who is a leading expert in neuro-oncology. She is the interim chief of neuro-oncology at the Yale Cancer Center. She's been with us at Yale for just a little more than a year and has an interesting journey to us that I will be asking her about in just a little bit. So, Sylvia, thanks so much for being here with us tonight.
Thank you very much for having me.
I want to start by just asking you what made you want to go into the area of neuro-oncology, focusing largely on brain tumors, both in terms of the clinical care and potentially research and new treatments in this area. What got you interested? Was there something that sparked you early on?
Yes. So when I went to medical school, I really just loved the brain, and I'm one of those neurologists who likes to localize and pinpoint where the problem is sitting. And I during medical school also, I have a PhD. So my PhD is in multiple sclerosis or neuroimmunology, which was a way of me getting interested in immunology at large. And then, my life path kind of brought me to the U.S. for training purposes. So I matched for neurology residency, and during my intern year, which is the first year of training, all neurology residents do a full year of internal medicine training. And just by chance, I happened to be on quite a few of the rotations on the cancer wards. And I just loved that kind of work. I mean, of course, it's grave illnesses, and of course, these are very sick patients. But what I liked, one, was the collaborative team approach that kind of goes into this, right? We're working together with surgeons, radiation oncologists, palliative care. There's a lot of multi-specialty approach in this. And then two, I just like the connection that you have with your patients.
Sure.
So I think, yeah.
Let me just ask you, if I can just jump in for a sec. What made you come to the U.S.? So you grew up and you went to medical school and did your PhD in Germany. What brought you here?
The short answer is my husband.
Okay, that's totally fair.
So the person I was dating when I was in medical school, he wanted to train in the U.S. because he was talking about how great the medical training is. He very early on during our relationship already had kind of gone through the USMLE steps and the match process. So he landed in Cleveland, Ohio. So we had a long distance relationship. He was in Cleveland, so Midwest. And
where were you?
I was in Germany.
Yeah, you were in Germany. And then when you came to the U.S., where were you?
I was also in Cleveland. So
Okay.
I wanted to spend time with him. So I spent a lot of my rotations as a medical student in Cleveland. And then ultimately, you have to make a decision. Either he comes back or I come here. So I matched for residency in Cleveland too.
So, I was going to get into this later, but we'll just touch on it now. Oftentimes in the U.S., we're a bit biased against people who do clinical training outside of the U.S. And we feel very strongly, often, not always, that people have to do their clinical training in the U.S. if they're going to practice medicine in the U.S. You had sort of the opposite experience. You came here from Germany. You did your training here, and then during COVID, found yourself needing to go back to Germany for complicated reasons, and you found yourself in Germany. And my understanding is they sort of looked down on you because you had training in the U.S. and you didn't have German training. Is that an accurate way of putting this?
That kind of is true. Yeah, it was a little, I will say I had great training in the United States, and I have a high regards for the system or how training is done here in the US. But yes, I found myself in this position that I was fully trained, 10 plus years experience, and then came back home and they kind of looked at me as I wasn't fully grown up yet.
Right. Yeah. No. And so fortunate for us, you came back here. So let's talk about brain tumors. I think people hear the term brain tumor and it strikes fear in most of us. But there is some variability in brain tumors, and there are some very worrisome brain tumors, some brain tumors often called glioblastomas that are hard to treat and very oftentimes end up with someone losing their life to the tumor oftentimes after some period of time. But then there are also brain tumors that are much easier to treat or much more responsive to treatment. So should we start off talking about what some of those are?
Yes, so overall, we recognize there are about 500 different types of tumors inside the head. So there's a lot of variability. And as you say, there are these very aggressive tumors, often referred to as glioblastomas at large. And then there are some others that some of them may be equally aggressive but treatable. One I would think of is primary CNS lymphoma, where we have about a 2/3 chance of achieving complete remission and even curing patients. These tumors or these lymphomas are even more rare than the GBMs are, but they are very treatable. They do require intensive chemotherapy treatments. But yeah, so that is a treatable type of a brain cancer.
And these are lymphomas similar to lymphomas that arise in people's lymph nodes and in other parts of their body, but they're isolated to the brain. I'm sure they're a little different when presenting in the brain. And interestingly, it's very rare for them to spread outside of the brain.
That is correct. So biologically, or how the cells look under the microscope, these lymphomas are similar to lymphomas that happen in the body, but there seems to be something special about them, how they kind of find their niche in the central nervous system and how they grow there better than elsewhere. So that makes them different from these body lymphomas. And for that reason, these lymphomas are staying within the central nervous system and don't like to go outside or spread to the body. There are, though, also secondary CNS lymphomas. So these are the kind of lymphoma that affect the body first and then spread to the brain as a metastases.
Got it. And what about meningiomas? Tell us about what these are.
Yes, so meningiomas are tumors that arise from skin-like layers that are covering our brains. And that we call
the meninges.
That we are calling the meninges. And there are meningiomas that, these are actually the most common intracranial tumors overall. They're not technically brain tumors because they come off of those meninges. And we do think of most of them as benign tumors that may need to be resected and then are watched. Some of them can be more aggressive, and they require repeat resections, may require radiation. And these are the ones where we try and work on finding better treatments.
And I realized that we're not coming close to the 500 different types of tumors you talked about. But then I suspect there are very few neuro-oncologists who have seen all 500 either. But then there's a group of brain tumors that are very clearly malignant, involve the primary tissue in the brain. They're not part of the covering layer of the brain. Oftentimes referred to as astrocytomas, but they're not always so aggressive, either acting or looking. And sometimes those are even curable. Is that correct?
That is correct. So there's a group of tumors called astrocytomas, and like a cousin of those tumors are the oligodendrogliomas. That
say that one more time, because I will confess that I had to practice saying that word about 10 times before I could have it come off my tongue.
Yeah, so the two cousins are astrocytomas and oligodendrogliomas.
Yes.
They are both most often they're both low-grade gliomas. So we recognize grade 1, 2, 3, and 4 tumors, and these low-grade gliomas are the grade 1 and 2 category. The grade 1 tumors and astrocytomas, for instance, like pilocytic astrocytomas are grade 1 tumors that can be cured by resection alone, or if you cannot resect them completely, you don't need to be treating them as aggressively. I think there it becomes more of a question, how aggressive do you want to be, and how high is the price tag of whatever treatment you would consider. And there, is where we care mostly about quality of life.
You're not actually talking exclusively about the price tag in terms of dollars, but in terms of toxicities.
Of course, yes. So, when we talk about chemotherapy or radiation, it's all associated with toxicity. And these low-grade gliomas, the majority of those happen in younger individuals, like in their 20s and 30s. So there we want to be very mindful about what we can do, what we must do to preserve quality of life and keep these patients in the active workforce, so they have a normal work life, normal family life. And sometimes that means we will postpone treatments.
And compared to the tumors that we're going to talk about when we come back from the break, which are the glioblastomas or the GBMs, which are typically grade 4 astrocytomas, so they're the most aggressive ones. How common are these grade 1 and 2 cancers?
They're 10 times more rare.
They're 10 times more rare. So if you hear about somebody with a brain tumor, unfortunately, more commonly, it is something that is more aggressive than these lower grade cancers.
True. Like the likelihood of having a more aggressive type of tumor is high.
So we're going to take a break. We will be back in just a minute, and we'll pursue our conversation about brain tumors. We'll talk about glioblastomas. We'll also talk about some recent research findings for some of these lower grade tumors as well.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where a multidisciplinary team of physicians employs state-of-the-art diagnosis methods for patients with sarcoma and other bone cancers. SmilowCancerHospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths. But when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Dr. Eric Weiner. I'm here returning for the second half of Yale Cancer Answers, and I'm joined by my guest, Dr. Sylvia Kurz, who is a neuro-oncologist, and our conversation tonight is about brain tumors. Before we talk about glioblastomas, I just want to talk for a minute about a recent, and by recent I mean within the last 2 years, a recent clinical trial and new treatment that was developed largely for patients who have lower grade brain tumors, not exclusively so, but this is a new targeted therapy that, when given, seems to delay the time until a cancer gets worse. This is the IDH1 inhibitor, correct?
It's an IDH1 and 2 inhibitor, but the vorasidenib.
I missed the 2, excuse me. This is what happens when you're not a brain tumor doctor.
Sorry, yeah. But no, sorry. The reason why I kind of said that is that it's like one of the big things that differentiate the vorasidenib from predecessor IDH inhibitors, that it covers both. And by covering or by addressing both the IDH1 and the IDH2, the group of patients that can be treated is a little bit larger because you have one drug for, tumors that have an IDH1 or an IDH2 mutation.
So this was a very exciting finding because it was a large randomized trial. It was at our big annual cancer meeting on the plenary session, very specifically because in the area of brain tumors, the progress has been somewhat less dramatic than in other areas. And tell us about what this drug does. In both, maybe very briefly about what it does mechanistically, but also what it can do for patients.
Yes. So IDH, standing for isocitrate dehydrogenase, is like a hallmark molecular marker that these low-grade gliomas do have. Low-grade gliomas are like either in the astrocytoma category or the oligodendroglioma category. And vorasidenib, or the brand name is Voranigo, targets this mutation. Within the cell, IDH are this enzyme is always present in all body cells, but in these tumor cells, it is changed, which kind of keeps the motor going of these tumor cells. So it's a little bit of like, you have like a little foot on the gas pedal within those tumor cells. So on the one hand, it keeps the tumor cells growing and going and driving tumor growth from that perspective. On the other hand, it forces these tumors in a slower growth pattern. So it's like a slow motion type effect. Now, vorasidenib kind of addresses that mutation and makes those tumors go even slower, or may even stop them from growing overall. So that's like the mechanism how this drug works. Now, why the so-called Indigo trial was so successful or was such a breakthrough in our field is that these tumors, the low-grade gliomas, like the grade 2s, predominantly affect young individuals in their 20s and 30s. And so far, until the publication of this trial, the best available treatment for those patients was to resect or remove as much possible surgically, and then either watch and wait until something happens, or if something grows, then go in and do chemotherapy and radiation. The consequence of treating with radiation and chemotherapy meant toxicity for those young individuals, and that has often to do with neurocognitive side effects. So with vorasidenib being successful in this study, it was demonstrated that this medication, which is a once-a-daily pill, the growth of these tumors can either be halted or slowed down to the extent that patients much later require more aggressive treatments. So from a quality of life perspective, this really means the world for those young patients.
And I think one of the things that patients in this situation, and many of the people we take care of, have to keep in mind is that if we have treatments that delay problems, who knows what we're going to have that's better in the future. Now it's an IDH1 and 2 inhibitor. In 3 years, it may be something entirely different, or it may be a better IDH1 and 2 inhibitor. But the key fact is that we need to have treatments that will allow people to continue to do well and to be there when the next breakthrough comes through, because the breakthroughs are coming really fast and furious. I want to talk now about glioblastomas, and it was now over 30 years ago that I was a fellow, and I met on some Saturday morning a neurosurgery resident who had been up, I thought, at least for 5 consecutive days, because she looked like she was about ready to keel over and was more than a little frustrated with everything in the world. And she spent about 10 minutes talking to me about how terrible brain tumors were. And what I've been struck by over these past 30 years is that we may not have a lot of new treatments, but we're doing a lot better in terms of helping people live somewhat longer than they did once upon a time, and that we're much more sensitive than we ever were to the issues that people face and their families face when they have brain tumors. So tell us a little bit about the treatment of glioblastomas and where you think that treatment has come over these years.
Yes, of course.
Recognizing that you don't remember 30 years ago.
I can imagine, yes. So glioblastomas are an aggressive form of brain cancer, and they do require aggressive treatments. There's no question about that. I think maybe 30 years ago, the treatment looked like biopsy just to make a diagnosis. Resection was difficult and scary because you could give the patient more symptoms. And then you would maybe do radiation. And that was it. And life expectancy after that was maybe a year if you were lucky. I do think we've come a long way since then. So today, treatment would consist of removing as much as safely possible of this tumor, which means improvement of any neurological symptoms for the patients. Patients do feel better. It improves quality of life after surgery, and kind of takes away mass effect, gives space for the brain to re-expand, for any tumor to kind of grow back into, and also minimizes the radiation field, the area of the brain that will subsequently get radiation. In 2005, so 20 years ago, we also, there's one positive clinical trial. So we have one chemotherapy agent that drives or improves survival for this tumor. And then I think the not to be neglected big advantage over the past 20, 30 years is that we care for these patients much better. I think there's much more detail-oriented care going into this. We're recognizing symptoms. We can deal with symptoms in a better way than we were 20 years ago or 30 years ago. We are seeing patients more often. There is much more of a multidisciplinary, symptom-oriented approach there. And I think we also do a better job talking to patients and their families about what to expect and how we can help them be supported in their daily life.
And has genetic profiling been of value in these high-grade tumors? Certainly something that we do more and more. But are we at a point where this is helpful as a matter of standard of care?
I think the honest answer to that is we're continue to be hopeful. that some of these targeted agents may be like a solution for a majority of these glioblastoma patients. We're not there yet. But I think the sequencing and like all this work that has gone into sequencing, understanding the molecular underpinnings of these tumors over the past decades really helped us understand better the biology of these tumors and helped us to kind of carve out some subsets of these glioblastomas that actually can be helped by targeted therapies. One success story in that area is that a subset, like a minority of glioblastomas, does have a mutation that also is commonly seen in skin cancer, the BRAF V600E mutation. And there have been a few clinical trials over the past 5 years that have shown that for glioblastoma patients whose tumors have that mutation, targeted therapy with a BRAF-MEK inhibition combo can actually be very useful. So I think that is like it doesn't benefit the whole group of all glioblastoma patients as of yet, but it demonstrates that targeted therapies could be useful at least for some subgroups of patients.
And there are always outliers, people who just do far better than you ever expect, sometimes for reasons that we can pinpoint, sometimes for reasons that we just don't understand very well.
That is correct, yes. I have one patient here in Connecticut who was diagnosed with a glioblastoma 15 years ago, and she's alive and doing well. And we don't know how and what she did to make this happen.
Sure. So this brings me to the topic of how you talk to patients and the importance of those conversations when somebody is facing such a difficult diagnosis. And of course, it's with a mix of being honest and realistic, but also being hopeful, because there's a place for that. And maybe you could just share your thoughts.
Yeah, these are always difficult conversations to have. And I think the same key features that you just mentioned, I try to kind of take them serious, right? We want to be honest, realistic, but we do not want to ever give up hope. And I do tell patients that during that first conversation, we do have treatments. Yes, we have to kind of go through aggressive treatments, and we want to do those treatments because we want you to get the best chance of being one of those outlier patients. There's always something that can be done. And we try to focus on the very first next best step and make a decision about that, and try to not get discouraged about the big picture and the what, if, when, and how. What's
your hope for the future?
For glioblastoma, that's, I think, will depend on combinatorial treatment approaches. Currently in the oncology world, we all talk about either chemo, traditional chemotherapy, or targeted therapy, such as the BRAF-MEK inhibition combination that I mentioned. Or the other world is immunotherapies that we haven't mentioned as of yet. But I think that for glioblastoma, it may require a combination of a few of those things in the future.
Dr. Sylvia Kurz is an associate professor of neurology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.